evening. My name is Muthoni Gichu. I'm a medical gerontologist and an exercise scientist, and I am a healthy aging champion. In today's session this evening, we will be having a conversation that will be led by Dr. Hafsa Zuber. And Dr. Hafsa is an obstetrician, gynecologist, a reproductive endocrinologist, and a fertility specialist with a keen interest in women's well-being and a firm believer in a holistic approach for every woman. She has a special interest in menopause, and this came hand in hand with a fertility practice when she realized that instead of laying out options for fertility, it was important that she would start managing the depletion of ovarian function. She is fully committed to being an advocate for comprehensive approach to women's midlife health and healthy aging. And she also has a very keen interest in PCOS epidemic. She loves practicing as an obstetrician, and that is what she enjoys, making the difference in the world. You're welcome. And so today we will be having a conversation on non-hormone therapy for menopause symptoms. Karibu daktari.
Thank you very much. Good evening, colleagues and friends. I thank you for having me today. I thank Cox Coast for hosting us today. I would like to take you through non-hormonal therapy for menopausal symptoms in a one-of-its-kind series on menopause, Beyond the Pause. So I have a long presentation, but I hope you will be with me throughout this presentation. It will shed light on our midlife women who present with symptoms which are neither here and there, and will resolve some confusion, some light on how we can manage them, especially in the stage when patients don't want to go for hormonal therapy. So, menopause is a critical event in the life course for women, both in terms of physiologic changes as well as the effects that such changes have on quality of life. It is experienced very individually, especially the climacteric. We can roughly divide our patients in three groups: those who do not have symptoms, those who do have complaints but can manage the symptoms, those who have symptoms and need help. So for such, what exactly can we offer them? And what can be an alternative to hormonal treatment? So I have started with the climacteric because it is the most eventful part in the onset of menopause, and the part where women are generally on a roller coaster ride and are looking out for some kind of treatment or management. So So who is non-hormonal pharmacological components or compounds and alternative medicine recommended for in menopausal therapy? In women who have history of breast cancer, it can either increase the risk of developing a recurrence, or women who have known mutations in BRCA1 and BRCA2 genes. In women who have heart disease, who have had a previous clotting event, who have had a stroke, women who have unexplained vaginal bleeding, or have a history of high-risk endometrial cancer or Lynch syndrome, and women who have active liver disease. Key points to note. Some women may opt for complementary and alternative treatment despite not having any contraindications to menopausal hormonal therapy. Others have a contraindication to use of hormonal MHT and yet need symptomatic management. Non-hormonal treatment can be pharmacological or herbal or Ayurvedic compounds, and it can also include alternative and complementary treatment. Herbal and or Ayurvedic compounds are not regulated, and therefore we cannot be entirely sure of their safety profile and side effects. Many of these might have minimal benefit or a placebo effect. We also have to remember that none of the products in use is natural. Natural is the hormones that are in your body. Every compound that you take in undergoes a rigorous processing line. So there are many herbal botanical products that are campaigned, advertised, touted as natural. And of course, that would appeal to us. We want to be as natural as possible, and that would appeal to us. But let's remember that natural is the compound that's in your body. Some of the body identical hormones recommended for MHT are also extracted from plants. So, for example, the progesterone that is recommended for menopausal hormonal therapy is actually extracted from yams. Non-hormonal treatments are used for relief of targeted symptoms and do not confer an overall benefit. So, climacteric symptoms, like I said, that it is the most disturbing period, the onset of perimenopause. So the vasomotor and cardiovascular symptom, the hot flushes, which are the most disturbing, night sweats and or cold flushes, insomnia, palpitations, and headaches associated with it, CNS and mental changes, difficulty in concentrating, memory lapses, emotional changes, irritability, mood swings, depression. Musculoskeletal, there's back pain, pain in muscles and joints, and this is a leading symptom in some Asian countries. Urogenital symptoms, urinary urgency, vaginal dryness, and discomfort during sex. Sexuality, changes in libido and sex drive. Then the miscellaneous touching the body image, addition weight gain, especially around the abdomen, dry skin or eyes, thinning of the skin, and hair loss. So moodiness, depression, and anxiety. Around climacteric, estrogen levels are erratic and fluctuating from 1 minute to the next. Less progesterone is also produced. Estrogen increases the production of serotonin. Serotonin regulates serotonin synthesis and modifies its metabolism. Serotonin has an effect on the mood and sleep behavior and decision making of a person. Estrogen also affects dopamine and endorphin synthesis in the brain, the feel-good chemicals. Anxiety and depression symptoms may contribute to sleep disturbances that are common during menopause. During the menopause transition, there is a significant increase in risk of new onset depression or relapse of depression. The risk decreases again early after menopause. Mood swings are a part of aging for many women. Steps to help prevent and manage mood swings. Often a healthy lifestyle is the first step in preventing mood swings. Avoid caffeine, alcohol, and spicy foods. Eat a balanced diet with fruits, vegetables, and whole grains. Talk to a therapist or counselor. Cognitive behavior therapy. Get enough sleep. Exercise regularly. Find healthy ways to deal with stress. Hot flushes. These are the most common and bothersome menopause-related symptoms, affecting up to 85% of menopausal women with various severity, frequency, and duration. They start during the menopausal transition and can last around 7 to 10 years. Some women experience hot flashes for longer periods of time, and some women experience for the entire life after climacteric. Hormone replacement therapy is considered the most effective treatment. However, it is not indicated for all patients, such as for those with a personal history of hormone-dependent cancers, venous thromboembolism, and cardiac disease. Many women with no contraindication to HRT still refuse hormonal treatment. And some physicians are still reluctant to prescribe HRT as a result of the scary Women Health Initiative findings. And for such physicians, we need to read up and we need to find more evidence that is coming up presently. So management of vasomotor menopausal symptoms with non-hormonal strategies. Non-pharmacologic therapies include mind-body techniques such as cognitive behavioral therapy, clinical hypnosis, and mindfulness-based stress reduction. Weight loss, exercise, yoga, acupuncture, and paced respirations are thought to have an effect. Dressing in layers, wearing breathable fabrics, and using fans or cold packs may help. Pharmacological therapies. There are various non-hormonal pharmacologic treatments for vasomotor symptoms. These include SSRIs or selective serotonin reuptake inhibitors, SNRIs, serotonin norepinephrine reuptake inhibitors, gabapentinoids, clonidine, oxybutynin, neurokinin B antagonists. SSRI and SNRI in general have a baseline effectiveness of 20 to 50%. Class effect of SSRIs is they also have an antidepressant benefit and improved quality of life. Side effects of SSRIs include initial effects such as nausea, dizziness, short-term aggravation of baseline anxiety and mood, and sexual dysfunction, such that sometimes patients don't adhere to the therapy because of the initial side effects. Patients on onset of therapy should therefore be encouraged to persevere and, if necessary, take treatment on alternate day. Paroxetine is an SSRI that is FDA approved for treating moderate to severe postmenopausal vasomotor symptoms. Dosed at 7.5 milligrams daily, lower than the dose used for psychiatric indications. Side effects include nausea, dizziness, and fatigue, which are dose dependent. Now, there's a potential medication interaction with tamoxifen through CYP, cytochrome P450, and that would render tamoxifen less effective. Other SSRIs and SRNIs with evidence for efficacy in treating VMS include venlafaxine, with a dosage of 37.5 milligrams to 150 milligrams. This has no interaction with cytochrome P450, so it may be the safest choice for patients who are on tamoxifen. Fluoxetine or Prozac, dosage of 20 milligrams, has a baseline effectiveness of 10 to 20%, should be avoided in patients taking tamoxifen. Sertraline, dosage of 25 to 50 milligrams. There's little information on its baseline benefit. Sertraline is the best anti-anxiety SSRI, but it does interact with cytochrome P450, so avoid in patients on tamoxifen. Gabapentin, gamma-aminobutyric acid analog, which is used to treat epilepsy, neurogenic pain, and migraine. It reduces hot flashes at a dose of 900 milligrams per day in about 50% of the patients. The benefits are improved quality of sleep, reduced pain, and side effects include dizziness, confusion, fatigue, and mood changes. Pregabalin at a dosage of 50 to 300 milligrams in divided doses can be used as well. The baseline improvement is similar to gabapentin, and it is better tolerated than gabapentin. However, it is costlier. Clonidine has also been used to treat vasomotor symptoms, though it has significant adverse effects that limits its use. Some of the adverse effects include hypotension, rebound hypertension when discontinued, headaches, lightheadedness, dizziness, dry mouth, constipation, and sedation. Oxybutynin, an anticholinergic and antimuscarinic medication used to treat overactive bladder, has been shown to be effective in treating vasomotor symptoms at a dose of 2.5 to 5 milligrams per day. It's used as an extended release tablet. The side effects include dry mouth, constipation, and blurred vision. Other data point to an association between anticholinergic medications and cognitive decline. Neurokinin B antagonist, a new class of centrally acting medication for the treatment of VMS. Fezolinetant is an investigational oral non-hormonal neurokinin 3 receptor antagonist that is currently under FDA review to treat moderate to severe VMS. It targets the kisspeptin, neurokinin B, and dynorphin neurons to help regulate the thermoregulatory centers in the hypothalamus to treat hot flashes and night sweats. The most common side effect is headache. In the Skylight 1 phase 3 RCT, the most efficacious dose for treating moderate to severe vasomotor symptoms were 30 to 45 milligrams daily. Botanicals. The botanicals have been used since time immemorial and are in use even today. A variety of them are used by women. However, the evidence from clinical trials of benefits on menopausal symptoms is limited and conflicting. The thing is that there are no recognized international criteria for the design of clinical trials of alternative therapies, as there are for standard medicines and medical devices for endpoints of treatment and safety evaluations. Studies may use different products that are not chemically consistent, making comparison difficult. Herbs may contain many chemical compounds whose individual and combined effects are unknown. A major concern is that herbal medicines can cause unwanted effects and have potentially dangerous interactions with other medicines, both herbal and conventional. Most herbal medicinal products are unlicensed. They do not have to comply with quality and good manufacturing practice regulations. This has resulted in cases of poor quality, unlicensed herbal remedies in the market. Botanicals that are presently in use: phytoestrogens, that is soy and red clover, black cohosh, purified pollen extract, St. John's wort, long quai, ginseng, chestberry, ginkgo biloba, and Piper mystaticum. Black cohosh. This is black cohosh. It is Native American women have used the extract of black cohosh, Ecte resmosa, for centuries as a phytotherapy cure for many different conditions. Nowadays, black cohosh is indicated only for the management of climacteric symptoms. The mechanism underlying the bioactivity of black cohosh is still unclear. It acts like a SARM or a serotonin partial agonist, or as an antioxidant and inflammatory substance. Recent different clinical trials have shown no effect on the vaginal or endometrial thickness or on sexual hormone variation. This confirms the lack of estrogenic activity. In the HALT double-blind placebo-controlled RCT on 351 patients, black cohosh given up to 52 weeks determined no effects on vaginal epithelium, endometrium, or sexual hormones. So black cohosh for hot flushes in an analysis, in a systematic review. So hot flushes frequency and intensity, no statistically significant difference in systematic reviews and meta-analysis, and the same results were in RCTs in breast cancers. Night sweats and frequency, no statistically significant difference in systematic reviews and meta-analysis. And the same for RCTs in breast cancer. In RCT in breast cancer symptoms, there was significant improvement. Menopausal symptom score, that is the Kupperman index, the green climacteric scale, or the menopause rating scale, no statistically significant difference in systematic reviews and meta-analysis. This black cohosh, however, has a good safety profile in the general population. There is no increase in the thickness of the endometrium and no detrimental effect on recurrence rate in breast cancers and unlikely interaction with tamoxifen. Phytoestrogens, soy and red clover. Phytoestrogens are plant substances that have similar effects to estrogens. The most important groups are called isoflavones and lignans. The major isoflavones are genistein and daidzein. The major lignans are enterolactone and enterodiol. Isoflavones are found in soybeans, chickpeas, and red clover, and probably in other legumes like beans and peas. Oil seeds such as flaxseed are rich in lignans, which are also found in cereal bran, whole cereals, vegetables, legumes, and fruits. The role of phytoestrogens has stimulated considerable interest since populations consuming a diet high in isoflavones, namely the Japanese, appear to have lower rates of menopausal vasomotor cardiovascular disease, osteoporosis, and breast, colon, endometrial, and ovarian cancers. However, evidence from RCTs in Western populations is conflicting for both soy and derivatives of red clover. Phytos, IsoHeart, PhytoPrevent are EU studies examining the role of phytoestrogens in osteoporosis, heart disease, and cancer. A systematic review of 30 RCTs, which lasted at least 12 weeks, and with a total of 2,730 participants, assessed the efficacy, safety, and acceptability of foods and supplements, including high levels of phytoestrogens. That is, red clover extracts, dietary soy, soy extracts, other types of phytoestrogens for reducing hot flushes and night sweats in peri or postmenopausal women. 7 trials used a red clover extract in dosages of 40 to 160 milligrams daily. 5 of these trials, including a total of 400 participants, were combined in a meta-analysis. The reviewers found no difference overall in the frequency of hot flushes between red clover extract and placebo. 2 trials found a reduction in hot flushes with dietary soy, 5 with soy extracts, and 1 with isoflavone genistein. The reviewers concluded that there was no evidence that phytoestrogen treatments help to relieve menopausal symptoms, but may have a modest reduction in the number of flushes per day, and thus are of benefit probably to women experiencing a high number of flushes per day. As phytoestrogens have estrogenic actions, there are concerns about safety in hormone-sensitive tissues such as the breast and uterus, and interactions with selective estrogen receptor modulators such as tamoxifen and aromatase inhibitors. In a relatively large study of red clover, isoflavone users had no effect on breast cancer risk in women who had a significant family history. St. John's wort. St. John's wort has shown to be efficacious in mild to moderate depression in both peri and premenopausal women. Its efficacy for vasomotor symptoms remains to be proved. It interacts with many medications. It decreases the blood concentrations of cyclosporin, midazolam, tacrolimus, amitriptyline, digoxin, indinavir, warfarin, and theophylline. It may cause breakthrough bleeding and contraceptive failure when used concomitantly with oral contraceptives. In a recent RCT, women on St. John's wort reported improved menopause-specific quality of life and a non-significant improvement in hot flushes. So we go to genitourinary symptom of menopause. So genitourinary symptom of menopause, or GSM in short, is defined as a collection of symptoms and signs caused by hypoestrogenic changes to the labia minora, clitoris, vestibule, vagina, urethra, and bladder that occur in menopausal patients. It includes genital symptoms of dryness, burning, and irritation, sexual symptoms of lack of lubrication, discomfort or pain, and impaired function, urinary symptoms of urgency, dysuria, and recurrent urinary tract infections. Patients may present with some or all of the signs and symptoms. The spectrum of adverse consequences requires long-term treatment in many patients. Treatment options include both hormonal and non-hormonal interventions. So these are the symptoms as we discussed, and these are the signs which you'll find on examination: labial atrophy, decreased moisture, loss of vaginal rugae, vaginal pallor, decreased elasticity, higher vaginal pH level, leukorrhea, introital stenosis, pelvic organ prolapse, thinning and/or graying of pubic hair. For the urinary symptom, in addition to dysuria and urgency, will have stress or urgency incontinence, repeated and recurrent urinary tract infections, urinary frequency and/or nocturia, urethral prolapse or carincule, ischemia of vesical trigone, and meatal stenosis. So treatment options for GSM can be hormonal and non-hormonal. So today we are discussing non-hormonal, and we will go according to that. So non-pharmacological treatment would include lifestyle changes and physical therapy. So a detailed history should be taken to establish any potential contraindications to treatment. To identify modifiable risk factors such as smoking, which is linked to with an increase in estrogen metabolism leading to vaginal atrophy. A sexual history should be taken to establish if the woman suffers from vaginal dryness and dyspareunia and to determine the presence of sexual dysfunction. Women should be educated regarding the benefits of physical therapy, particularly in the presence of high tone or non-relaxing pelvic floor muscle dysfunction. Women should be advised that it is safe and beneficial to continue with sexual activity. Lubricants. The first-line treatment for the symptoms of vaginal dryness and dyspareunia is lubricants. Lubricants are used during intercourse. They are fast-acting and provide temporary relief. They're beneficial for women whose symptoms primarily occur with coitus. Lubricants are available in a variety of preparations. They can be water-based, silicone-based, or oil-based. Oil-based lubricants can cause a latex condom breakdown, and thus can be a risk for STIs and unwanted pregnancies. Lubricants are specifically designed to reduce friction-related irritation to atrophic tissues during coitus, increasing comfort and reducing dyspareunia. So these are the lubricants that are available in the Kenyan market. I know the most commonly used are KLY and Durex. Next comes moisturizers. Vaginal moisturizers are an excellent option for women who experience ongoing discomfort due to vaginal dryness. Moisturizers are hydrophobic and have bioadhesive properties. They are absorbed into the skin and adhere to the superficial cells of the vagina. They have the ability to retain moisture, which is then released locally, mimicking physiological vaginal secretions. A moisturizer can be used several times per week, independent of sexual activity. Moisturizers contain a variety of excipients targeted at preserving pH and moderating viscosity and the maintenance of vaginal elasticity. A recent meta-analysis of RCTs comparing moisturizers and lubricants to vaginal estrogen stated that dyspareunia significantly improved with both treatments. However, vaginal estrogen had an upper hand. Women should be advised to choose a product that is optimally balanced in terms of pH and osmolality so that it is physiologically more similar to natural vaginal secretions. Lubricants with osmolality less than 380 osmomoles per kilogram and a pH of approximately 4.5 is recommended to prevent vaginal mucosal damage, contact dermatitis, and sexually transmitted infections. Patients have traditionally used natural oils such as olive, coconut, and mineral oil for vaginal moisturization. But we are in the era of evidence-based, and there are no clinical trials to help to guide us in this aspect. So these are the vaginal moisturizers available in the Kenyan market. I particularly have just seen Riplans MD. I haven't seen this, and I have used this for my patients. Hyaluronic acid. It is a naturally occurring polysaccharide and is one of the main components of the extracellular matrix present in the epithelium of many tissues, including the vagina. It has strong antioxidant properties that connect water to tissue and is considered a naturally occurring reservoir of body water that can increase moisture levels within cells and improve atrophic symptoms. Hyaluronic acid has been widely used as an essential ingredient in topical hydrating and lubricating gels and has been injected for conditions such as dyspareunia. Prospective observational studies carried out on hyaluronic acid have shown that it is well tolerated among patients. A recent systematic review comparing the efficacy of hyaluronic acid and estrogen on atrophic vaginitis showed that all articles reported improvement with both treatments, though estrogen had an upper hand. So this is a moisturizing gel with hyaluronic acid. Lidocaine. So topical lidocaine of a concentration of 4 to 5% can be used for dyspareunia. It can reduce sexual discomfort by numbing the nerves that are stimulated during intercourse. In a double-blind RCT study of breast cancer survivors who lacked systematic circulating estrogen, dyspareunia symptoms were improved by applying topical 4% aqueous lidocaine in the vulvar vestibule before intercourse. Please note that although some women achieve improvement of symptoms from a good quality non-hormonal product, it is essential that women are advised about the endocrinological etiology surrounding these symptoms. That is, women need to understand that this is due to a depletion of estrogen and up to a certain extent androgen in their blood system. GSM is a progressive and chronic condition, and without the replacement of sex steroids, long-term resolution is unlikely to occur. So use of vaginal laser has grown in popularity as an alternative non-hormonal treatment for GSM. Through thermomodulation, these laser technologies result in the restoration of the vaginal epithelium to a state similar to that of a premenopausal woman. The controlled temperature rise causes collagen remodeling and synthesis, neovascularization, vasodilatation, and elastin synthesis. The safety profile surrounding energy-based devices in an area where robust research is leaking. In July 2018, FDA issued a warning to healthcare professionals declaring that the safety and effectiveness of these devices for vaginal rejuvenation or cosmetic vaginal procedures are not proven. In addition, it stated that no energy-based device has been approved for these procedures or the treatment of menopause-related vaginal symptoms, urinary incontinence, or sexual function. Complications reported in the use of laser are procedure-related pain, numbness, burning, dyspareunia, bladder disturbance, worsening of symptoms, scarring, and worsening of lichen sclerosis. So we come to another major symptom in the climacteric, which does affect the quality of life and requires management. The musculoskeletal symptoms. So as menopause approaches, estrogen levels fall. Joints are complex workings of bone, cartilage, muscle, ligaments, and the synovium. All these tissues are rich in estrogen receptors, making them highly sensitive to the hormone's presence. Studies show that estrogen maintains cartilage and other joint tissues and stimulates the production of synovial fluid. Thus, low estrogen levels mean reduced synovial fluid and more frictions in joints and thus pain. Estrogen has anti-inflammatory properties, so fluctuating estrogen levels during menopause lead to increased inflammation in the body. This can affect the joints and cause pain and stiffness. Menopause can also lead to sarcopenia, that is, a decline in muscle mass and strength. Since muscles support joint function, reducing muscle mass can leave joints more vulnerable to pain and injury. Joint pain is also common amongst people who use estrogen-blocking drugs like aromatase inhibitors and some SERMs. The decline in estrogen levels during menopause decreases bone density, increasing the risk of osteoporosis. Osteoporosis may lead to fractures and inflammation that can cause or worsen joint discomfort. If a patient presents with menopausal joint pains, rule out more serious medical causes like rheumatoid arthritis and fibromyalgia. Things that can help: exercise regularly. Motion is lotion. This is the latest catchphrase for exercising regular and reducing joint pain. Research shows exercise can reduce joint pain during menopause. Quit smoking, get an anti-inflammatory diet, de-stress, and lose weight. So, can supplements help with menopause joint pain? Certain supplements can support joint health and reduce menopausal symptoms. Omega-3 supplements, fish oil or algae-based omega-3 can help reduce inflammation. Vitamin D and calcium are essential for maintaining bone health. They reduce the risk of osteoporosis and ease joint pain. Vitamin D is crucial for calcium absorption. So the recommended dosage of vitamin D is 600 to 1,200 international units per day. And the recommended dosage for calcium is 800 to 1,200 milligrams per day. Glucosamine and chondroitin. Often used together, these supplements are popular for reducing joint pain and improving joint function, although studies on the effectiveness have mixed results. Magnesium helps maintain muscle and nerve function and supports a healthy immune system and keeps bones strong. Curcumin, the active ingredient in turmeric, has strong anti-inflammatory properties and can help reduce joint pain. Some studies suggest that collagen supplements can support joint health by strengthening the cartilage. Vitamin K is important for bone health and can help improve bone density and reduce fracture risk. Bone health and management of osteoporosis. For the prevention of osteoporosis, systemic estrogen MHT, menopausal hormone therapy, is approved via oral or transdermal preparations and is recommended, but it is not approved as a treatment for osteoporosis. So MHT is not approved as a treatment for osteoporosis. It is also important to remember that improvement in BMD and prevention of fracture do not persist after stopping menopausal hormonal therapy. Evidence for menopausal hormonal therapy for prevention of fractures comes from the Women's Health Initiative study, where MHT use was associated with a significant reduction in incident fracture risk, 28% for any fracture, 31% for vertebral fractures, 24% for non-vertebral fractures, as well as a 4.5 and 3.7% increase in bone mineral density of the lumbar spine and total hip, respectively. For women diagnosed with primary osteoporosis, the goal of treatment is to reduce the risk of fractures and improve bone mineral density. Bisphosphonates and monoclonal antibody-ranked ligand inhibitor, denosumab, are anti-remodeling agents that help reduce fragility and fracture risk by inhibiting osteoclastic bone resorption. They reduce risk of osteoporotic fractures by improving bone mineral density, but they do not fix the microarchitectural disruption of the trabecular structure of the bone. Biphosphonate formulations include alendronate, risedronate, ibandronate, and zoledronic acid. Biphosphonates can be taken orally, daily, weekly, or monthly, as well as intravenously every 3 months or annually. Side effects include gastrointestinal distress when taken orally and flu-like symptoms when taken intravenously. There is a small risk of osteonecrosis of the jaw and atypical femur fractures. Denosumab, the monoclonal antibody, or the rank ligand inhibitor, is administered as a subcutaneous injection every 6 months, and side effects include rash and infections, and a small risk of osteonecrosis of the jaw, as well as atypical femur fractures with long-term treatment. When denosumab is stopped, there is a rapid decrease in BMD and an increased risk for vertebral fracture. Anabolic agents work by building the bone and include the parathyroid hormone receptor agonists like teriparatide and abaloparatide, and the monoclonal antibody romosozumab. The PATH receptor agonists activate osteoblastic bone formation, thereby remodeling bone and improving trabecular bone mass. These are administered as daily subcutaneous injections and can be used for up to 2 years. Side effects include hypercalciuria, dizziness, and muscle pain. When discontinued, patients should be switched to an anti-resorptive agent to maintain bone mineral density and prevent further bone loss and decreasing bone resorption. Romosozumab is administered as a monthly subcutaneous injection. Side effects include injection site reactions, arthralgias, nasopharyngitis, and back pain. Romosozumab is associated with an increased risk in cardiovascular events and is not recommended in patients with MIs or stroke within the last year. In conclusion, it is important to understand and manage the symptoms of menopause, and especially the climacteric, as it has an impact on quality of life and long-term morbidity of the woman. It is important to understand that every woman is unique and will require a tailored management approach. A holistic approach is recommended and a multidisciplinary team is encouraged. Know your products well and recommend the best possible products. The science of menopause and aging is still young. Research is ongoing. Please let's keep reading and adhering to evidence-based medicine. Thank you. I can
Thank you
take
very
any
much.
questions.
Yes, thank you very much. There is one question on the chat. And Hanan is asking, hi, please elaborate on this diet that reduces inflammation.
Okay, the diet that reduces inflammation will be discussed further next week. This was just mentioned as, by the way, there'll be a whole presentation on lifestyle modification next week, and it will further be elaborated on. But basically, an anti-inflammatory diet would include substances that are known as anti-inflammatory. That is like turmeric, cinnamon, turmeric, cinnamon, and some other herbals. It also includes keeping away from processed foods, keeping away from highly refined carbs, and keeping away from seed-based oils, deep fried stuff, etc.
Thank you very much. Looking forward to hearing more questions. I know we are just about at that time of the hour. We have a feedback form that we will be sharing with all of us. kindly provide us with feedback. It helps us deliver better webinars, and it also helps us serve you best and see what it is and hear from you what it is that works best for you. The link to the feedback form is on the chat. You're very welcome to connect with us on the feedback form. There's one more question for you, Dr. Ari. Can magnesium supplements be used for management of insomnia and depression?
Yes, magnesium sulfate can help to a certain extent in the management of insomnia because I would say, and anxiety, because they act in the center, in the hypothalamic center, and basically they reduce anxiety and thus can result in having better sleeping patterns.
Thank you. I am looking for any other questions. Dr. Ari, thank you very much for such an informative session. It was great. It was a lot. I learned a lot myself. And it is interesting that we need to actually keep doing more research, and more so hopefully research that is country and context based. So calling to all of us to see how best we can contribute to research. Is there something that you would like to say as we get towards the end of this?
Is that for me?
Yes.
I would say that um, there are many there are many options and methods and therapies available for the you know for the woman who is in her midlife or who is facing midlife crisis. Please, let's explore them and let's optimize the management, and let's connect with our women and provide them the best that we can. We may not be having a lot of hormonal compounds, a lot of non-hormonal compounds that I have even discussed in the presentation, we may not be having the opportunities to discover a lot of complementary treatments as well, but there's still a lot. And let's explore and let's be able to provide our patients the best. And every time we talk to our patients, let our approach be holistic, comprehensive, and let's not be scared of involving a multidisciplinary team. And everything starts with lifestyle changes. Thank you.
Thank you very much. And thank you, team, for being with us this evening. If we have no more questions, I am happy to give you back 5 minutes of your time this evening. We appreciate you joining us and being with us on this forums and through this webinar series. We will have our last webinar for this series on Monday next week on the 18th. And kindly look through and talk to us through the feedback form. Thank you very much. Enjoy your evening and have a great week ahead.